So hello everyone, now we are live. I would like to start by welcoming you to this session on circular healthcare. My name is Thilda Ingelsten and I am a sustainability advisor at the Nordic Center for Sustainable Healthcare. I would like to start by introducing some instructions. In your right-hand corner, you have a chat function where you're welcome to post questions or comments. And it's a good idea to post these questions during the presentations as we're short on time in between speakers. The speakers which are not currently presenting, I would like to remind you to please make sure that your microphone is muted. The rest of you do not need to worry about this as your microphones are automatically muted. And the topic of this session is circularity. It's an ever-trending sustainability concept that is slowly but surely making its way into sustainable healthcare sector as well. And circular healthcare is a term, of course, built on the concept of circular economy. And this we heard some about in the plenary from Jody Sherman. And circular economy, it contradicts the traditional linear model of take, make, and waste. So when rethinking the path from construction to waste, components such as design, material composition, lifespan, energy consumption, and downcycling, and even upcycling, it needs to be considered. And hence it's a very complex system. And in effect, the line between what is considered to be a part of or not a contributing part of circular healthcare is somewhat blurred. But by strategically switching focus towards and integrating possibilities to recycle, to reuse, redistribute, reprocess, and even refurbish or repurpose, we're on the road towards a circular and sustainable system. Our end goal is effectively to create an ecosystem that is regenerative by design, and in the long run allows for the decoupling of economic growth from finite resources, and thereby also global health and well-being. The reduction of our environmental impact is both a corporate responsibility, but it's also a way to mitigate long-term risk. And in this session, we will hear from 4 experts who are on the road and path towards a circular healthcare sector. So first up, I would like to welcome Dr. Martin Minehan, who is the Anaesthetic Senior Medical Officer at Auckland District Health Board in New Zealand. Please, Dr. Minehan, the floor is yours.
Thank you very much. I hope you can all hear me. Thanks for inviting me to this session. I've been asked to prepare a brief talk on the going circular at Auckland District Health Board, and that's in New Zealand. So I'll start the slide share, I suppose. So firstly, I'd just like to say, Kena katoa. This is the traditional Maori greeting in New Zealand. As you can see, Auckland District Health Board has adopted the World Health Sustainability Goals, and we've partnered with various institutions to enable us to start our journey on the sustainable pathway. Just a brief overview of how we view the World Health Sustainability Goals. As you can see, there's 3 levels: biosphere, society, and economy. And at the very top, the 17th goal, which is partnership. And this ties in quite nicely with the Treaty of Waitangi, which is the founding document of New Zealand, that, among many other things, emphasises partnership in the governance of the country, and in our case, in the delivery of healthcare. Just to put New Zealand into perspective with their Nordic friends, as you can see on the map there, we're at almost at the bottom of the world. Can you see the mouse? Yeah. The realm of New Zealand actually includes several smaller island groups. In terms of demographics, we're not too dissimilar from most of the Nordic countries in terms of population and surface area, and in terms of economic performance. Auckland District Healthcare, it's the largest health provider for New Zealand. It's the largest employer in the Auckland region with over 11,000 employees. We provide healthcare for over 500,000 patients, and we're expecting that to grow by another 100,000 towards 2025. The life expectancy of an Aucklander is about 83 years. And we have almost 5,500 births per year. Quite quite a diverse cultural group. New Zealand in itself is quite a diverse country. We have Maori and Pacific Islanders, a large Asian population. A reasonable percentage of that is represented by students who come over here to engage in tertiary education. We've got two main hospital sites, two campuses. There's actually four main buildings that provide the healthcare on those two sites. We have about 1 million patient contacts a year, generates almost 3,500 tonnes of waste, use over 3 million litres of water, almost 90 gigawatts of energy, and are responsible for over 38 million passenger kilometres of staff travel. And as you can see, Kiwis like to fly, and it's partly because we are an isolated island nation at the bottom of the world, and to get anywhere, to go to conferences, we traditionally had to travel. Regardless, our carbon footprint has been coming down significantly over the years, and this is primarily due to a reduction in staff and academic travel. In terms of waste volumes, it's a bit of a problem for us. Waste volumes are continuing to increase year on year, and that's predominantly general waste as opposed to medical waste. As you can see, our patient contacts have remained pretty consistent, yet our waste volumes continue to increase. And back in 2015, we were generating about 2.5 kilos of waste per patient per day, and now we're up to 4.8. And that's from a number of reasons, but primarily because of the increase in single-use medical devices and equipment. Recently, last year, the government redefined the procurement rules for sourcing medical equipment, but this is, for all businesses, including healthcare. And there are four main priorities that that need to be considered when acquiring goods and services for a government-owned organisation. And priority 4 was only introduced in 2019, which requires government agencies to consider emissions and waste as part of the procurement process. In terms of procurement, just to put that into context, you can see that we are engaged with local and national suppliers, international suppliers. There are various stakeholders involved. There are government buying agencies. New Zealand has a big pharmaceutical buying agency called Pharmac. So all government-funded medications are funded via the pharmaceutical budget, and Pharmac basically is a buying organisation that enters into contracts with pharmaceutical companies in order to supply medications at a fixed price. Pharmac is a little bit controversial, but it's estimated that it saves us between $2 to $3 billion a year, as opposed to going to the free market for pharmaceuticals. We also engage our patients, our whānau, which is families, staff and visitors, and all these factors contribute to have an influence in our purchasing and procurement. Most importantly, particularly with the talk of going circular, is our partnerships. So we are a member of the Global Green and Healthy Hospitals. We're also a member of the Sustainable Business Network of New Zealand, and we're in partnerships with various suppliers who are helping us with our sustainability journey. So I'm just going to use the next part of the talk just to go through some examples and illustrate some of the smaller and also some of the larger projects that we've engaged in and had some very good outcomes from. Right, so I'm going to just very quickly cover these topics. So we recently partnered with BD. They're a medical plastics manufacturer. For us, they exclusively supply almost all of our plastic syringes. and we end up using roughly 33 tons of plastic syringes a year. These were all previously going straight to general waste. They weren't being recycled. A small percentage was ending up in the sharps waste stream, obviously, because they were either sharp or were contaminated. But the majority of it was ending up in landfill. So BD, we approached BD about whether we could look at doing something in this space, and they were more than happy to work together with us in partnership. And so we've launched a syringe recycling program. This is in its pilot stage. It's still being tested across 7 operating theatres, so the Women's Health operating theatres, which consist of 4 operating theatres, and the Starship operating theatres, which are the paediatric operating theatres. Auckland District Health Board has 40 operating theatres overall across those 2 campuses. So they were happy to do this because it was a world first for them. There had been attempts at previous recycling schemes by another hospital a couple of years ago, but that required the removing of labels and disassembling of the used syringe, i.e. removing the rubber bung, and it proved to be too difficult a process for people. So we can now recycle the syringes whole. They can still keep the rubber bung. They can still keep any labeling, and you'll see later on that most of our syringes end up labeled with a barcode for administration. The provisos are that the syringes are not contaminated with human body fluids, so no blood, no CSF, no other human fluids, and they can't have been used for chemotherapeutic agents, and they can't have any sharps on them. So these would be syringes that you might have drawn up some antibiotics, or for me as an anaesthetist, I might have drawn up some propofol or some fentanyl or something as such, and it's been administered to the patient, and then any remaining drug is expelled into a medical waste container, and then the empty syringes are collected up. And you can see they've made these collection bins, so there's one of these in each of the operating theatres, and these get collected up, put into a large 120 litre bin, which then get taken down to the loading bay, where they're collected by BD. Once they're collected, they're sent to a company in New Zealand called Future Post, and they're made into fencing posts that you can see here. And these are beginning to be widely used throughout New Zealand. They're very durable and strong and lightweight, so good for long fence post runs, like you can see here in orchards and stuff. So we, like I say, we're still in the pilot stage, but we're measuring the output from this, and we're collecting around 2 kilos of used syringes per operating theatre per week, so that's about 15 litres. And we estimate that across the 40 operating theatres, we could collect up to 4 tons of plastic syringes a year. So that's 4 tons of waste diverted from landfill. At this stage, if the program goes well, we'll roll it out across the other operating theatres, and then eventually, hopefully, across the entire organisation. And already word's got around, we've had many inquiries from other hospitals and other DHBs wanting to know what's happening in terms of the syringe recycling. So there's been quite significant interest, and all going well, we're about to roll it out across most of the hospitals in New Zealand. Okay, on to the next project. So the next project is surgical instrument recycling, and this is in partnership with Johnson & Johnson, the manufacturers. So we've put these instrument bins, you can see them here, they're big bins, foot operated, and in those bins they collect used single-use laparoscopic instruments, arthroscopic instruments, harmonic ultrasonic scalpels, as well as stainless steel instruments. So here's some pictures of the bin there. As you can see in the second picture, the bin filled with used ensure devices and laparoscopic staplers, and this bin over here filled with these rather dreadful single-use scissors. Unfortunately, there's been quite a big shift from the suppliers into single-use metal surgical instruments. However, these are collected up and then they get broken down by Johnson & Johnson into the separate waste streams, and they can recover up to 90% of the product by weight. So it's roughly about 40% metal and 60% plastic from the laparoscopic instruments. And then these go into the various recycling waste streams. And we started this in July last year, and so just over in 1 year's time, over the course of a duration of a year, we've diverted 2 tons of instruments for recycling. Okay, another project. Now, I know PVC is controversial, and a lot of people are moving. We're trying to move away from PVC plastic in healthcare, but unfortunately, for New Zealand, we still use PVC fluid bags. This is part of the government procurement contract with Baxter. So PVC issues aside, where Baxter have introduced a PVC recycling scheme throughout Australia and New Zealand. And this was launched in 2014 and now includes 30 hospitals within New Zealand. And per annum, Baxter collects roughly 100 tons of PVC, and this comes from the IV giving, the fluid bags, I should say, and a lot of the oxygen giving equipment is also PVC, so PVC masks and PVC oxygen tubing. Oops, sorry, let's go back there. And these are then collected and remanufactured into other products, primarily these playground mats. I don't know if you have those in the Nordic countries, but a lot of the playgrounds here have these thick, soft PVC mats to reduce fall injury in playgrounds. And you can, this is like the collection bin, and then they get, in the processing, Baxter shred them into these tiny little particles that then get sent to the mat company. Another project, there's a company in New Zealand called MedSalve. They've entered the market in the single-use equipment reprocessing field. So they collect up single devices that would normally be considered single-use, and for us at the moment, these are the calf compressors, the sequential calf compressors, the thromboembolic devices. And these calf compressors are sold from the manufacturer as single use, but they're actually quite thick and durable. So MedSalve have started a process where they collect up the used calf compressors in these bins. They get taken to their processing plant. They are checked for damage, barcoded and tracked, cleaned to the ISO certification, tested, and then sent back to us. And for the calf compressors, they can be processed up to 30 times. They get about 20 times processing average out of them before they fail the testing. And this has resulted in significant cost gains. It costs us about 40% to 40% of the original cost price of the calf compressor to have it processed and repackaged and sent back to us. And obviously, this saves us a great deal of waste to landfill. We are about to start reprocessing the hover mat. So these are the these air inflation mattresses that are used to transfer obese or overweight patients or patients who are significantly immobile between beds. So moving somebody from a ward bed onto an operating table with these sort of hover mat things. So that's been quite an exciting development. Oh yes, the drug trays. So we've been using these plastic drug trays. You can see a picture of the plastic one down here. I presume you can all see the mouse. Yep. So we've been using these plastic drug trays. So these are trays where you would draw up some medications or some IV administration equipment and put it in a little tray and use that to take it to the patient bedside or to the operating table. So anaesthetist, for me, for example, we'd draw up all the drugs that we need for a case and store them in these drug trays. The trays that we were using were type 5 plastic polypropylene. They were costing us over $1 each, and we use about 2,000 of these trays a week, and they were ending up in landfill. They weren't being recycled. So we spent some time looking at this, and we got samples of various drug trays from different suppliers from Australia and New Zealand, and we asked each of the suppliers to a series of questions so that we could attempt a sort of a very rough sort of paper napkin cradle to grave exercise. So we asked the manufacturers what materials I should say the trays were made of, which country they were manufactured in, what the energy mix was in the manufacturing process, the transportation methods, and how to dispose of the product at the end of its use. And we came across a really good New Zealand product, a company called Earth Pack or Potato Pack, and they make these drug trays out of potato starch. So this is a byproduct of the potato processing industry. So when you go to get your chips or French fries or your crisps that have been processed, they would have all gone through a processing facility where they would have been washed and cut and washed again and so forth. And a lot of the washings from the potato processing contains quite a lot of starch, potato starch. So this company gathers up the potato starch slurry and through extrusion molding, manufactures them into various trays, and so we engaged with them to come up with a product design that suited our specifications. And so now we have these potato trays. They're 100% potato starch, so not derived from plastic, oil-free. They are rapidly biodegradable. In fact, you can actually eat them. They taste a bit like the Catholic communion biscuit things. So we don't encourage people to eat them, but should you get hungry in theatre, you could eat one of the drug trays. And they're much cheaper than the original product, so about a quarter of the price. And the great thing about these is that they are actually carbon negative in their manufacturing, and should they end up on the road or in the waterways, they'll dissolve within a matter of days, and you could feed them to ducks and fish if you like. So this has been quite a good win for us. As part of the process, we surveyed staff to see what they thought of them. There was an initial little bit of resistance, oh, they're not as rigid as the other ones, oh, they feel a bit light. But once people got used to them, it became a non-issue. And so now these are the standard drug trays that we use across all our operating theatres. Okay, a couple of smaller projects. Polystyrene is a real issue. I'm not sure how the Nordic countries deal with polystyrene, but for New Zealand, it's very difficult for us to process. There are only a limited number of processing plants that will take bulk waste polystyrene from certain manufacturers, but polystyrene isn't a waste stream, isn't a type of plastic that's available for processing in the New Zealand waste streams. So we were using hundreds of thousands of these polystyrene cups in the hospital, so primarily for hot drinks. And so we had a bit of a conversation about this and looked at ways that we could reduce, if not eliminate, the polystyrene cups from our purchasing facility. So we did a case study. We looked at one operating theatre. So this is the tea room of the operating theatre that I work in. These are a couple of the nurses here, and we costed it out, and we were working out. We costed out that just that one tea room alone was spending roughly $3,000 a year on polystyrene cups, and that excludes the cost of waste processing. And so we were able to convince the managers that it would be actually cheaper and more environmentally friendly to buy a dishwasher and run that than use these polystyrene cups. So eventually you can see here, people started bringing in their own cups. We bought a couple of boxes of cups, and now everybody exclusively uses the porcelain cups in the dishwasher. And so this was quite a success, and then other departments wanted to get involved, other operating theatre tea rooms and various facilities around the organisation, and now we've completely eliminated the polystyrene cups. In fact, you can no longer find them on the ordering system. And then just a couple of fun things. I mean, what's really important for us is staff engagement and sustainability, and the uptake has been fantastic. Everybody's wanting to do something. Everybody's looking for opportunities, and particularly the younger staff, so the trainees and the junior nurses and the registrars and stuff. You know, sustainability is very much forefront in their minds. So, you know, they come up with clever ideas. So these are plastic holders for supraglottic airways, a brand called iGel. So they've turned this one into a Christmas tree. This is all the surgical wrap, the Kim Guard, that's been turned into Christmas decorations. And these are propofol bottles. So people started collecting them up and putting them through the dishwasher to get rid of any remaining drug, and they've turned them into spice jars, and they just happen to be of a very similar size to a brand that's sold in New Zealand, and that fit in these pre-made drawer liners. So one of the nurses was very proud to show me that she's replaced her entire spice cabinet with the propofol bottles. Okay, so just finishing up. We've certainly engaged in engaging in the sustainability pathways. We're making significant attempts to reduce our greenhouse gas emissions and minimise our environmental footprint. Sustainability is becoming more important, more of a priority in our procurement processes now, which has been supported by the government mandate, and we're trying to improve the life cycle impacts of our current and future products. We're working on a few other projects. We're trying to reduce our sharps waste. We've got some issues with the cafeteria, in particular the number of single-use plastic items that they still retail, but there are some contractual issues there that we can't get around, unfortunately. But yes, definitely heading in the right direction. And just some more examples here. You can see pictures of staff engagement. We have several sustainability days where we have exhibitions in the entranceway in high traffic areas to capture staff engagement. So lastly, takeaways, key takeaway points. So we already aligned with most of the goals. We just need to measure and execute that. We understand that the sustainability is actually more than just carbon and waste, but with the engagement strategy with our supply partners, we can begin to work our way up the three layers that I mentioned at the beginning. Obviously, critical systems thinking is an important part of that, and staff engagement. Okay. So it's been quite good. We've won a couple of awards. We got 3 gold medals in the Healthcare Without Harm awards. We've won a climate challenge for significantly reducing our carbon footprint. But this is all as a consequence of teamwork and staff engagement, and I have to give props to our sustainability manager, Manjula. She's been fantastic, and a lot of this wouldn't have happened without her. She's very good at playing to the various people's strengths. Just standard conflict of interest disclosures. I have no pecuniary, monetary interest in any of the products or manufacturers that I mentioned in the talk, and no declarations in terms of significant gifts. And this is our sustainability team. This is Manjula here in the middle, holding up the certificate for the 3 gold awards. And these are our champions. You can see nursing staff, clerical staff, admin staff, and pharmacists, biomedical engineers, allied health professionals, and various management staff. That's it. Thank you very much.
Thank you so much, Dr. Minehan. And thank you so much again for joining us despite the time in your zone. I guess it's 2 o'clock in the morning, isn't it, at your location?
Yeah, 1:15 in the morning, and I've got work tomorrow.
Well, then I'll be short. One thing I'm thinking about is that geographically New Zealand is very similar to, for example, Iceland, which is a Nordic country. So what would be the major key outcome that you would like the Nordic citizens to take or learn from the New Zealand example?
Oh, that's a good question. I went to the Clean Med conference that was in Nijmegen several years ago, and was really impressed at how far along the pathway the European countries are. So I'm not sure there's actually a lot that, I'm not sure there's anything major that we're doing that the Nordic countries aren't doing, and probably the reverse is true. We've got a lot to learn from the Nordic countries. I guess I would probably advocate for lobbying the government, and particularly for us, it's lobbying the government purchase division. So as I mentioned, Pharmac and Health Benefits Limited, Health Alliance are the 2 big purchasing companies from the government. And there was no, in the original terms of reference from several years ago, there was no mention of sustainability as part of the purchasing agreements with suppliers. But after lobbying and people saying this, this needs to be an issue, this needs to be a consideration, that has now been put into their purchasing priorities. So really, collective voices, collective action, and encouragement of people that are showing an interest in this space.
Thank you. And I actually think that's a perfect transition onto our next person concerning lobbying, which is Daniel Vukelish, who is the president of the Association of Medical Device Reprocessors. So thank you, Dr. Minehan, and I would like to give the floor to Daniel Vukelish.
Well, thank you. I appreciate that you are holding this conference even virtually, and I do think our presentations are going to meld together pretty well. Let me pull up my slides. So my name is Dan Vukelish. I'm the president of the Association of Medical Device Reprocessors. And today I want to talk about creating a circular economy, primarily in Europe, though of course I can speak to this issue in other jurisdictions for medical devices. So I'll give you a little background in terms of the agenda about AMDR and who I am and what it is we do. I think the COVID crisis has highlighted, as Dr. Jody Sherman had pointed out in her plenary section, that there are vulnerabilities in the healthcare supply chain, and our reliance on disposable products has been featured on the shore. I'll talk about SUD remanufacturing and SUD single-use devices and the urgent action needed for European states right now. So just to give you a little bit of background, about 20 years ago, I started representing a handful of small third-party companies that were reprocessing or cleaning and sterilizing medical devices. In fact, medical devices that were often labeled for single use. This was perceived as something that was unacceptable by some, but the companies that I represented at the time knew that they could safely and effectively reuse these products despite that single-use designation by the manufacturer. We shortly thereafter became regulated by the U.S. Food and Drug Administration in the U.S., meaning that our products could meet all the same safety and efficacy standards as new. And so that legitimized the industry. And since then, what we have been doing is growing as an industry and demonstrating in various countries that our products, like a generic drug, would, compared to a brand name drug, prove to be just as safe and effective as the original equipment. The members of my association are both third party, but I also now represent the subsidiaries of much larger device companies. I think companies like Stryker or Arjo, Cardinal, and Medline have invested in medical device reprocessing and remanufacturing because they realize that the circular economy is going to happen with or without them. And so they want to make an investment that speaks to the interests of what their healthcare partners really want, which is lower cost, more environmentally friendly medical device options. I won't go through, in the interest of time here, the history of reprocessing, but as I mentioned, the culinary date sort of for our industry was in 2000, when FDA began regulating reprocessing of single-use devices as manufacturing, and therefore subject to all medical device manufacturing requirements. Germany in 2002 took a similar approach, regulating the practice. And now the European Union has been the latest to act in 2017, passing the medical device regulation, which, though extended for a year because of COVID, will be fully implemented now by May 2021. In the intervening period, we did see other countries adopt sort of this approach where they would treat the reuse of a single-use device as a manufacturing activity and therefore subject to manufacturing requirements. So we have it in Canada, we have it in Japan, and I think that there will be other member states in Europe and other places across the world that are going to adopt this type of approach. So my job at the association and representing these companies is to interact with medical device and Ministry of Health agencies, those that would oversee us to ensure our products are safe and effective, but also standard setting organizations. And so that's really the context of which I'm presenting here today. Is we have a big opportunity in Europe now to allow these products, meaning they need to meet the same standards as if they were new, but each individual member state needs to act. But first, COVID changes everything, and that's sort of the cliche statement, but really COVID has revealed that healthcare is toxic. Other speakers have noted here today how toxic healthcare is, but the COVID crisis has just created mountains of additional PPE and other waste that we didn't have pre-crisis. The crisis itself is also breaking the bank. American hospitals are being particularly hit hard. But American hospitals were already particularly expensive. And so the cost associated with fighting this pandemic necessitates that we more prudently use the medical device and supply assets that we have in order to reduce costs to extend care to all the patients in need right now. Also, the supply chain lacks resiliency. What we discovered with the shortages of PPE and N95 respirators is that we forced, as Dr. Jody Sherman pointed out, hospitals into reusing devices that were labeled by the manufacturer as for single use. But unlike the remanufacturing validations that my manufacturers have done, hospitals were forced to do so out of necessity, with no cleaning instructions, with very little validation, with little to answer for what would happen legally or regulatorily, but simply because we had to. So I want to talk a little bit about the single-use label. Dr. Jody Sherman in her plenary talked about the drastic move in the last 3 decades from reusable to disposable. And she talked about how there are various market factors beyond just concern for patient safety that push things into being labeled for single use. And so I'll talk a little bit about that. But my whole business is predicated, my members' whole business is predicated on reusing or extending the lifespan of devices that have been labeled by the manufacturer as for single use. So obviously a lot of people would ask, why would you reuse anything that's clearly been labeled for single use? And so I thought I would explain that in a little bit more detail. Here's an example of a pulse oximeter sensor. These are devices that nearly every patient in a hospital would have. I think this is a particularly egregious example at $174, where I see in Europe or the US, the average price point may be 18 to 24 euros or dollars. But you'll see in the handle of this device, or what gets hooked into the computer, we have seen manufacturers insert microchips into the devices so that they'll stop working after they've been used on a single patient for a single use. So this is the manufacturer enforcing the single use restriction by forcing obsolescence into the device. Doesn't mean the device wouldn't work, but it means they're trying to ensure that the hospital buys a new device after every patient, after every use. If this is 18 bucks every time, and if the patient rips this off to go to the bathroom 6 times a day, that's 18 bucks, 18 bucks, 18 bucks, 18 bucks, 6 times. And you can imagine the price just goes up with no added patient safety benefit. So Dr. Jody Sherman had mentioned in her introduction that the big swing towards disposable or plastic medical devices began in the 1980s. Not only did we have better plastics, but the introduction of the HIV pandemic at that time, with the concerns at that time on what little we knew, created a demand for disposable versions of devices. And so the first thing many medical device manufacturers did was simply switch the label on devices that used to be labeled as reusable to now being for single use. And frankly, there's been no turning back from there. The presumption has been it's safer, it's cheaper, it's faster, and these devices will always be available. And I think the COVID crisis has underscored that we should not presume those things to be the case. From a regulatory perspective, the single-use label is chosen by the manufacturer. It's not chosen by the regulatory agency. In fact, my area of practice, I'm a medical device attorney. I don't know any regulatory authority in the world that requires any device to bear a single-use or reusable label. In fact, it's much more regulatory burdensome to label a device as for reusable. When a manufacturer submits data for a device that they seek to have placed on the market, if you label it for single use, you only have to prove that it's safe and effective one time. If you choose to label the device as reusable, you have to do a cleaning validation, you have to write cleaning instructions, you have to validate those instructions and validate that cleaning protocol, and you need to demonstrate to the authority that that device will continue to be safe and effective after each cycle. That becomes very expensive from a regulatory perspective, and so manufacturers have an incentive to just label devices as for single use. But this is also an area where there's some gray area. The universe isn't black or white, and devices aren't wholly reusable or single use. There are many instances where manufacturers over the years have included instructions on how to clean a single-use device, or as I said, have switched the labels on devices for reusable to single use, but told their customers there's been no material design change. And some of my members included, and other medical device manufacturers reuse or remanufacture their single-use devices. And so this has sent confusing messages to healthcare and resulted in this whole cottage industry where we have commercial reprocessing and remanufacturing companies. So the disposable paradigm and culture of healthcare today, talking about the financial environment and now the safety costs and supply chain failures, looking at this through the lens of COVID and looking at it in terms of the hierarchy of materials management. If you remanufacture or reprocess a medical device, that's one less device that's required of the healthcare supply chain to create. So ideally, I see our industry as helping to prevent the creation of needless new medical devices because we are reusing what we already have. As Martin had pointed out, as a third best option, in my view, we can recycle those materials when they reach the end of life so that we're not putting them into incinerators or landfills, which could only become problematic later, or burning those products for energy by incineration before going to landfill. Okay, I've used several words, and so I think I should provide some clarification. Reuse. Reuse is a term generally that people worldwide in hospitals will use to describe what you do to a medical device before you can use it on another patient. Reprocess is a term that is specifically used in hospital central sterile departments with regard to what happens to clean, decontaminate, sterilize, package devices to be reused between patients. And that applies to both single-use or reusable. Now that regulations are changing, and the EU, Japan, the UK, and the US are treating the reuse or reprocessing of single-use devices as manufacturing, the term that's being adopted is remanufacture. So I'm using the terms intermittently, but when I talk about reprocess, I'm generally referring to what hospitals are doing. And now when I talk about remanufacture, at least with regard to single-use devices or SUDs, I'm talking about regulated medical device firms, whether they're an original manufacturer or not, that have to prove that they meet the same standards before they're allowed to put their product to market. So in our view, remanufacturing of certain single-use devices promotes a more resilient, cost-effective, and environmentally sustainable healthcare supply chain. We reduce the consumption of new devices. We put less pressure on a global supply chain. We help build a circular economy in Europe or wherever these devices are being used. We keep the financial resources that would otherwise be spent on buying new devices at home in our hospitals or in our countries, rather than global conglomerates or to manufacturing outfits in Asia. And then by remanufacturing, we keep it closer to home, meaning in New Zealand, in Europe, in the United States, rather than outsourcing those manufacturing operations for raw material and equipment largely from Asia. Right, so what am I talking about? The devices that my members have achieved FDA clearance or European CE marks for are in 4 basic categories: orthopedic and arthroscopic devices. These are largely made out of metal or surgical grade stainless steel, surgical saw, blades, bits, burrs, external fixation devices, clamps, a lot of use, and it just doesn't make any sense to be throwing all that kind of metal into an incinerator. We do a lot of non-invasive devices like blood pressure cuffs, pulse oximeter sensors, Martin had pointed out, air transfer mattresses. And then the 2 areas that are invasive that we do are in the cardiovascular area, particularly electrophysiology catheters, and in the laparoscopic surgical area. Martin's slides had pointed out a number of, for instance, electrosurgical single-use instruments. You know, these things can cost 250 euros to 500 euros a piece. The typical ultrasonic scalpel, you need 2 to 3 per procedure, so the device costs are very expensive, and so there's a big incentive to try to remanufacture that. So the linear model that we've had requires hospitals to buy more in order for medical device makers to make more. And so a circular economy would put the incentives aligned with manufacturing as it exists right now with remanufacturing. The more hospitals remanufacture the devices, the more money they save, the more business there is for the remanufacturer. And so that's the model that we're looking to see promoted as we look to a circular economy for healthcare, at least with regard to medical devices and supplies. We've largely rewarded device companies based on volume. And so they make more money the more they sell to us. And AMDR envisions a future where we're not in a healthcare paradigm that demands more waste and volume, but demands greater value. And so we would like to work more with medical device makers to make equipment better, to make it reprocessable, and if it can't be reprocessed in the hospital, to make it remanufactured, either with us or with another medical device maker who has an expertise in those product lines. All right, as I mentioned, we have new European regulations. In 2017, Europe passed a new medical device regulation, and Article 17 of that regulation deals with the reuse or reprocessing of single-use medical devices. I tell you, I've been involved from the very beginning in Europe, and each member state has taken the approach to reprocessing and remanufacturing differently. But the one thing I sadly think most have in common is the see no evil, hear no evil, speak no evil. Reprocessing ended up being one of the most contentious elements of the medical device regulation, and I don't actually think it's because we were on the same page with regard to the facts. We have countries like Germany that have regulations in place that allow for the reuse or reprocessing of single-use devices according to very high standards. We have a lot of poor EU member states that prohibit the reuse of single-use devices either by statute or regulation, but for practical purposes know that hospitals are reusing single-use devices. Not to pick on any member states in particular, but wealthy member states like Spain or Ireland or France have had policies that simply ban the reuse of single-use devices, but studies show that it's happening. One study in Spain showed that 85 to 88% of central sterile managers admitted to reusing some sort of single-use device, either because it was too expensive to buy more, because they didn't know it was labeled for single use, or largely out of the urging for the physicians who wanted that device back again. So until now, there's been no consistent policy, and so individual member states have been allowed to regulate this as they see fit. But we now have a big opportunity with the regulation being implemented within the next year, but each member state has to act. The pathway allows for remanufactured single-use devices if they meet all the same standards as the regulation requires of all other devices, and it has to be allowed in each individual member state. So ordinarily, devices just have to get a CE mark. Remanufactured devices have to get a CE mark and be allowed by the member state, which means Germany and France and Italy and each member state has to proactively review their regulations to decide whether or not they want to allow this. And so that's going on right now. So that's going on right now. And so I'll provide a little bit later as we're wrapping up this section here where we are in each member state. But the argument that I'm making in promoting remanufacturing is that this reduces waste, it lowers costs. I've heard this adage before that if your sustainability efforts are costing you money, you're doing it wrong. And in fact, medical device remanufacturing should cost less. A remanufactured single-use device could be 60, 50, 40% less than the cost of buying a new device. It also builds healthcare supply chain resiliency. We're not having to tap into that global supply chain because we use what we have. From a safety perspective, I also think this regulation is an opportunity for those member states that do not want to have their hospitals reusing single-use devices to affirmatively address this. The regulation gives member states a tool by which to stop inappropriate hospital reprocessing, but they have to opt into allowing CE marked remanufacturing to give hospitals the legitimate lawful pathway for getting lower cost, environmentally preferable products. So we support the regulation. This ensures that all healthcare professionals will have consistent access to safe and effective medical devices, including remanufactured devices. This will help stop inappropriate hospital reuse. It legitimizes the commercial industry and provides a pathway for manufacturers to create remanufactured products, promotes the circular economy in Europe. And so we're encouraging member states to opt in and asking for our friends and allies who want to see help to see us build a more circular economy for medical devices to help us do so. So here's where we are. In terms of where member states, and we call this the opt-in, they have to take action. Already before their Brexit, the UK effectively opted in, meaning they allow such products. Netherlands has also done so, and I expect soon to see Belgium, Germany, and Turkey's regulations allowing such. I do know nations like Croatia, Portugal, Slovenia, Spain, and Sweden are affirmatively taking action to investigate this issue. And whenever a member state actually spends the time to investigate this issue, we get the result we want, which is they understand the difference between reprocessing or what's happening in hospitals versus what's happening in a controlled, regulated remanufacturing environment. And they have all come to allow remanufacturing. I'm most concerned about likely bans in Austria, the Czech Republic, Poland, Slovakia, and Switzerland. In each of these instances, sadly, and I don't know what happened, I do not think their regulations, which we've seen, contemplate that there is a difference between reprocessing and remanufacturing. They presume them to be the same and therefore are moving forward with a ban. This is really sad, as in each of these countries we have done business before. In each of these countries they had been okay with such products in the past, and now that the standard has been upped, they have suddenly decided to take a different course. And so those are countries that I'm looking to make friends with if anybody wants to help me out. And then most member states, but including the Baltics, Denmark, sadly, France, Hungary, Italy, Norway, and Romania have done nothing, as far as I know. So in summary, we believe that SUD remanufacturing helps to promote patient safety and public health by making sure all devices are safe and effective, reduces costs, promotes competition, reduces waste. It provides a level regulatory playing field between manufacturers and remanufacturers, and it helps build a more resilient supply chain. So we're looking and encouraging most EU member states to opt in.
Thank you so much, Daniel Vukelish. Very interesting to hear about your insights concerning the reprocessing industry and your the future trends concerning what will happen. One question I had was concerning, do we want to recirculate all types of materials, or are there any type of materials you do not wish to reprocess in the healthcare sector?
Yeah, in fact, most single-use devices cannot be reprocessed. And maybe I should have said, but if you look at the universe of what we can scientifically validate that is labeled for single use that can be reused, we're talking 2 to 3%. That's based on our data. But at the end of the day, the check on this is that you have to get a CE mark, meaning anybody that wants to reprocess anything and put it on the market has to demonstrate that it's safe and effective, and no notified body is going to sign off on the remanufactured version of anything that can't be proven to be safe and effective beyond a single use.
Of course. Perhaps the other speakers have a question for Daniel.
Thank you for that. That's very inspiring. I've just got a question. How do you counter the prion argument, or the CJD prion issue? Because for a while there, that was a big problem for a lot of people, particularly medical devices that have been exposed to mucous membranes.
Right. Well, this is a concern that I know notified bodies and competent authorities have sought to have addressed as well. Number one, we do not reprocess or remanufacture anything that is used neurologically, in the eyes, in the spinal tissue. And so that's one way of simply saying that there's a low risk. Another way is that we ask our clients not to send us anything that may be involved in any of that tissue that's known to transmit the prion. But also a lot's changed even in recent years. I do know that the notified bodies in Europe have actually required of us to include in our routine testing an assay that can detect for prions, which I guess is now commercially available. Even on product lines, which I think is a little redundant, that would be used in orthopedic surgery or thoracic surgery. And so they do actually require us to test and validate a protocol to ensure that there's going to be no risk of cross-contamination of prions.
Thank you.
Thank you so much. And if there's not any more questions in the chat, I would like to thank you so much, Daniel. Henrik Peters is the managing director and owner of the innovative company Paxxo. They are the inventors of the unique bagging system Longopack and have become the standard way of packaging waste in certain sectors.
All right, good afternoon. Henrik Peters, CEO of Paxxo. A little bit about us. We are the biggest continuous liner manufacturer in the world and are the inventors of the Longopack system. We are a Swedish-based packaging company, headquartered in Malmö, 45 employees. I think you recognize this by now. Dan talked about that. That is the Lansing ladder. And we have heard a lot about how to prevent, how to reuse, remanufacturing. I'm going to talk about the other 4 things, which is a very big area. The average European generates 5 tons of waste per year. So we have a lot of things to do, and 45% goes into the landfill, which is a big problem in that end. I think we all know that the way forward is to work more circular. You have the biological cycle where you want to generate biogas or compost soil, and you can do that by biodegradable material. We have been working with that for over 20 years with a biological biodegradable material. We recommend that, of course, only for organic material that should go into compost. Then you have the technical cycle, where you want to work with labels, signs, and different colors of your waste bag to create different waste streams. You have to, of course, educate the staff so they put the right things here. And we saw from the case in New Zealand that 80% of the waste is general waste and 20% is clinical waste. And of course, you first have to make sure that you don't put things into the clinical waste, which is more expensive and more CO2 consuming. But 80% you can do a lot of things with recycling. Is this good packaging, sustainable packaging that you see here? I don't think in any product you would accept half full boxes or cans or and things like that. You really want to use 100% of the material. But when it comes to waste management, you allow for this. You have oversized bags, you have containers that is limiting the space of the bag, and in many operations you cannot have full bag. You have to change after every operation, shift changes if it's smelly, or you have a service provider that is doing what we call a milk run, that is changing everything at one go. I think if you have 6% filling, then you are very good. But in many hospital operations, you're down to 30% filling due to all those reasons. So what we're really talking about is packaging of the waste. It can be recycled, or it could be things that go to incineration. Waste bags is top 3 items in a hospital plastic consumption. The majority of the CO2 is consumed at the end of life. If you see here, this is a life cycle assessment that we've done together with TEM. It's looking at 125 liter traditional waste bag. The purple and green, which is production transport, generates 20%. And of course, you can produce this with fossil-free energy like we do, or you can have short transportation by local sourcing and things like that. But the problem is how much material you use and what kind of material it is. And we're going to look at how you can go from this, which is the normal situation, to better solutions when it comes to waste management. This is a growing problem. We've become more people in the world, and waste generation increases more than the people growth. We saw on the New Zealand example that also the hospital waste increases with the single-use items. So there's a lot of ton of waste or liter of waste that is handled in every hospital. This is a waste bag with a 60% filling degree, and it looks full to many people, but this is only 60% filling degree. This is how it normally looks with very low filling degrees. So what some hospitals do, which is almost a mission impossible, is to find a lot of different bags that fit the different containers. And you end up in so many different bags, so the staff don't know which bag to use, and it's difficult to source and things like that. So we have a new standard for packaging waste, and that is using a continuous liner. The overall advantages with this is that you make very quick bag changes in 30 seconds, so it's very efficient and time saving. The other thing is hygienic, because you never touch on the opening of the stand. You only touch on the outside. And then further, it's environmentally friendly. Why is that? We have managed to make the world's strongest polyethylene film, so we can have half the thickness. It's always 100% filling. You see in below here, you see that we're using cable ties, 2 cable ties and cut, so you always have 100% filling. And then we have sustainable production in Sweden with fossil-free energy, and we have been able to reduce energy per meter with 40%. In the life cycle assessment that we have done with PM, it shows that it's about 70% saving in plastic, oil, and CO2. But we have focused everything on minimizing the CO2. That is our goal. The other thing you can do instead of one thing is, of course, minimizing the raw material and the filling degree. and the thickness of the material. The other thing is which kind of material you are using. Here you see a simple schematic of fossil plastic and bioplastic. And the plastic is divided also in non-biodegradable and biodegradable. And here's a big confusion in the industry. For example, biodegradable doesn't always mean that it is fossil-free. Normally, they hide this information from you. And many times it's as low as 20-25%. That is starch or vegetable oil and things like that. The rest is a fossil-based polyester to keep this together. But they try to hide that from you. So don't go into that loop to think that this is better, but just because it says biodegradable. The most common in soft plastic is PET. This is a biodegradable polyester. Then the other thing is bio-PE, that a lot of people talk about that. This is a Brazilian company called Braskem that from sugarcane make ethene gas. They make ethanol, and then they make ethene gas, and they make polyethylene, which is PE. So from a chemical point of view, it is exactly the same, but it's from renewable content. And then we're talking about 100% renewable content. Obviously, you have maybe longer transportation. You have also a process to make this, so it's obviously it takes CO2 to make green PE. So don't be fooled by that it's zero, because that's how that could be labeled at some point. So let's look at some of the cases that was in this LCA. It's 4 different versions of the longer pack system, and it's 4 different versions of the traditional waste bag. We are looking at virgin PE, recyclable PE, green PE, and biodegradable plastic. Before moving on, we also have to realize that packaging waste or having a waste bag have a function. And the most important function is, of course, that it's not breaking or leaking. If it leaks, you create the risk for your staff that they will slip and have an accident, and you have extra cleaning and things like that. And you have contamination, or you have other bad things happening. So you should never sort of compromise with the function. Here we see a lot of hospitals that have defined the function in terms of thickness of the bag. For example, we have a case in Catalonia, Spain, where they say the bag has to be 50 micron thick to work. That is like saying that a car should at least have 1 liter per 10 kilometers, and we don't care about horsepower. That is almost, that sounds very stupid, right? So why define thickness instead of the strength? The most common way to define the strength of plastic, and that is to measure dart drop. It's an international standard. You can look at the YouTube to find how that looks like, that test. Here you see the different bags. To the right is the traditional bags, to the left is the longer pack bags. And you can see, for example, that the biodegradable bag have less than 100. Okay, so in the industry, we say it have to at least 100 dart drops. So in this case, this bag is not working. When you move to recycled plastic, like the sixth example, you have less strength because many times recycled plastic have less strength. I think the best case, if you're going to use a traditional waste bag, that is to use green polyethylene. That you can have the good strength and you have good sustainability. However, all those new plastic, which is only 1% of the total production, is 3 to 4 times more expensive. So you have to balance your cost and your functionality, right? To the left, you see the our material, and you see also the thickness here, 18 micron. We do 400 grams. That's extremely strong and the world's strongest. And right now we have been able to make the longer pack in a recycled material, 50% recycled material, with the same strength, which is quite revolutionary. The longer pack biodegradable is thicker and the strength is less. And that this is the case. Especially if you increase the renewable content. We have 50% renewable content, which is among the highest in the industry. So this is stronger than a traditional waste bag in many cases, but we have to go up in thickness just to meet the strength. We have also done trials in green PE, but we can't get the same recipe, the same strength. So we are still working on that one, but we don't want to go up in thickness just because we can't produce that. So looking into the details, in the middle you have the traditional waste bag, what people are currently using in many cases. And then you see, if you go to biodegradable or bio-PE, that you reduce it. So you save about 30% by going to green polythene. But if you go to continuous liner, you save about 70%, and even 80% if you go to the recycled version. So this is quite substantial saving in CO2 and plastic by doing this. So a little bit about the conclusions and the recommendations I would give to hospitals that want to save here on your waste management. And that is to increase your recycling and reusing, of course. The function is the key. Specify your strength requirement rather than the thickness. And balance the cost and the requirement. Knowing that recycled component can lower the cost sometimes. It depends on, there are some recyclable plastic, the high quality ones, can actually be more expensive than the virgin plastic. If you go to bioplastic, they are always much more expensive. We're talking about 3-4 times more expensive on the actual material cost. The focus should be to minimize the raw material that is used to package your recyclables or waste. And you can do that by improving your filling degree, using the right bag to the specific container, or use a continuous liner. And when it comes to biodegradable, it doesn't mean fossil-free. Always ask for a material data sheet, ask them to specify CO2 content or CO2 emissions, or how much that is renewable or fossil based. And bio-based doesn't mean biodegradable. You really don't want a green polythene item into the sea or into the nature. And measure your CO2 content, measure your CO2 emissions, and we recommend to measure that per liter waste, because that is the function, and that is a package, a volume, not kilo, it's volume, right? One good example of this is Region Skåne. They currently use 130,000 cubic meter in longer pack. They have made a 75% saving on CO2 and plastic. And last year it was 170,000 kilo CO2 saving. They measure all different plastic items and have done that for many years. And the next step for them is to start using our recycled material. And this is when they got the CO2 certificate to prove that saving. And I think both these guys, Lars and Christina, they are happy seniors now. But I think they were very happy that day, and I think that it's important to always measure these kind of things and see your progress. So that's all for me. I hope it inspires some of you to challenge your waste management.
Thanks a lot, Henrik. And I would like to pass over the mic to Dorethe and Nielsen. You do not need to worry about the remaining time, as I can prolong it by 5 more minutes. Dorethe is the Vice President of Corporate Environmental Strategy at Novo Nordisk. Novo Nordisk is a multinational pharmaceutical company and the world's largest insulin producer. So please, Dorethe, the floor is yours.
Thanks a lot, and thank you for some very interesting presentations. A lot of new knowledge, at least from my side, so thanks a lot. So I am heading up the corporate environmental strategy area in Novo Nordisk. So I'm overall responsible for our environmental footprint and also responsible for one of our new biggest initiatives in terms of environmental sustainability that is called the Circular for Zero. And as you just mentioned, the Novo Nordisk is a healthcare company, and we are the world's largest producer of insulin. And obviously, what is one of our biggest concerns is that the insulin for most users are delivered in a plastic device. So obviously, that's a big challenge for us in order for us to figure out how can we, make sure to maybe reuse this. All right, I was just starting to introduce Novo Nordisk, but obviously a healthcare company, the world's largest producer of insulin, and we have activities in globally, and our global company 43,000 employees. So of course a lot of good colleagues to help addressing some of the sustainability issues. What I will be discussing or talk to you about today is a little background on our new environmental strategy called Circular for Zero, where we are very much inspired by circular economy. But I want to go a little back before I introduce the strategy and actually say that this year we will achieve a target that we set 5 years ago, that all our production sites will be powered by renewable electricity. So that is actually kind of an achievement and something that of course we are proud of. So that has actually kicked off, you can say, our whole sustainability journey, and really to not only focusing on our manufacturing processes, but really to have a full value chain perspective, being able to address not only our production but also suppliers and our products. So obviously we have challenged ourselves to make sure that we constantly kind of define new targets and ambitions in order to continue to be a sustainable business. The Novo Nordisk's biggest environmental challenges are 3. First of all, it's the resources that we use, and it's not only the resources in production, it's also the resources that we use in general for driving our company. And it was very interesting to hear just the last presentation talking about the different types of plastic, because that is also something that we of course are investigating as we deliver our product in plastic devices. So good to see kind of the difference in biodegradable, bio-based, and so on. We also focus very much still on our CO2 emissions. So now kind of having fixed the CO2 emissions from our production, then we start working with what comes around. So that's company cars, business flights, product distribution. And obviously an interesting thing was kind of, what have we learned from COVID-19? And obviously in terms of travel, now that all of us have worked from home for many months, maybe some are still doing that, that we can really learn from the way that we have engaged with each other, and hopefully we will not go back to the same level of flying as before COVID-19. And then on the last part is the waste, and usually we talk about waste as a waste from our production, but actually we do have that pretty much in control. So only 1% of our production waste ends up at landfill. The rest are being reused or being reused or burned with energy production as part of it. But what we talk about here is the waste from our patients. So every year, Novo Nordisk, we sell up to 500 million devices. Most of them are not single use, but patient can use them, for maybe 5 or 10 times. But as long as, or when the device is then empty, then they cannot use them anymore, and it ends up at landfill. So of course, how can we deal with that, and how can we, in a good way, retract some of that good material, because obviously it is very, very good material in a high quality. So finding a way for a take-back system is also some of the challenges that lay ahead of us. This is our environmental ambition to have zero environmental impact. And of course, it's an ambition that for some people might seem a little unrealistic. I'm not sure that we are going to achieve this when I'm around, but at least it's important for a company like ours to aim high and really ensure that when we do that, also some of the good innovations and some of the good learnings come across. So that's our ambition. And when we created the strategy, we was very much inspired by circular economy as a way to achieve the zero environmental impact. So we have kind of translated circular economy into those 3 action points here. Of course, the best thing you can do is to minimize consumption. So whatever you do, try to figure out, do I really need to buy this, or can we, live without it? The next one is about eliminating waste. So no matter what you do, try to eliminate waste. And if you cannot do that, then think about, can this waste be used by others as a new resource? And then lastly, really focusing on our own products. So figuring out how can we design and produce our products so they can be recycled. So those are the 3 principles that we try to work with across the organization in order for us to minimize our environmental impact. We have divided the strategy into 3 key areas. The first one being circular supply. So addressing our suppliers, working together with them on how can they achieve a circular mindset. The middle one being circular company, so still working on our own footprint as a company, and the last one being about our products. In order for us to get started, we defined 7 projects, each with targets towards 2030. So we have 7 projects that are running in parallel, each with dedicated project managers, budgets, and resources. And I'll just briefly go through the projects just so you can get a sense of what we are doing. The first one being reducing our supplier footprint. In Novo Nordisk, we have 60,000 suppliers. So we think that one of the biggest impacts we can actually have is to work with our suppliers to have a zero impact, and hopefully then they will inspire their suppliers, and then we can have kind of created a movement. The project number 2, or focus area number 2, is about what we buy. So really have a stand on the things that we buy. That is, for instance, not only plastic in production, but also our IT equipment, our tables, chairs, and whatsoever. So work with suppliers to ensure that the goods that we buy are sustainable. Then project number 3 is about the climate. It's about our CO2 reductions. So not only focusing on our production, but really also on transportation. So ensuring that our company cars are shifted to electrical vehicles, that we minimize flying, and also that we're focusing on how we transport our products using ships and trucks instead of flights. Project number 4 is about eliminating waste of energy, water, and materials. We do need to use energy, water, and materials when we produce our products to the benefit of our patients, but of course we should do that with the lowest possible waste. So that is something that we really do focus on. We also have a big focus on our sales affiliates, so whatever they can do out in the society to work with different governments in order for them to reduce their environmental impact. And then the last one about our products. Our products have a very long time from R&D until kind of they hit the market or the patient, so to say. So it's very important for us to have sustainability or environmental parameters integrated as soon as possible in the design process. So really think about how can we ensure that the devices we design for the future are fit for circularity. That could, for instance, be that we focus on using renewable materials, that we focus on that the devices can easily be assembled and into different fractions and other things. And the last one is about the take back that I mentioned in the beginning. So how can we design a system where we makes it possible for all patients to deliver back their used plastic pens either to the pharmacy or wherever they buy or get their drugs or their medicine, and then make sure that we can kind of cross down the used devices and recirculate the used material into other products. I would say of those 7 projects that we have started here, then project number 7 is definitely the most challenging one. So I was very glad to hear some of the good examples from New Zealand that actually that is possible. So maybe that could also be good to share some knowledge on what you have actually done in a little more details after the session. So just a few examples of what we have been doing already. We have went into a partnership with a design company, a Danish design company that produces chairs. So some of the waste, the plastic waste from our production, we have actually produced a chair. So I don't know whether you can see it, but it actually says on the chair that this chair used to be 120 insulin pens. So it's important for us that whenever we kind of try to reuse or close the loop in terms of materials, that we also ensure that the material are used for something that actually have a high quality. Last year at the General Assembly in New York, we actually brought the chair just as a way to see what is actually possible, and it got a lot of attention, and it's a good way to show that it is actually possible to reuse plastic. The thing I will round up with is the symbiosis in Kalundborg, which is a symbiosis, industrial symbiosis with partnership of 11 companies working together to reuse each other's waste. Excellent example of how companies can work together and use circular economy as a way to reduce the environmental impact. Thank you.
I would like to thank you all for powering through despite time zones and technical hiccups. And I hope to see you all next year live at the Nordic Conference, the 5th one in May in 2021. So thank you, everyone.
Thank you.
Thank you.